Yep. Hi, my name is Roland DePrati. I am a graduate student in data science. I want to thank Penny and her team for allowing me to speak today. I was especially interested in the speakers on palliative care because it's often the case that the things we're interested in studying are things that in some fashion we've experienced ourselves. I went back to graduate school in 2020, and a year after, actually 6 months after I went back, I ended up having a vestibular event that over the course of the next year, I was evaluated 3 times with 3 different diagnoses. So as I was looking for, as I got over that, as I was looking for a thesis problem to study, I started reading a bunch of articles, and I found 3 things that kept reoccurring in a number of articles. The first was, and this is an example of one of the studies, is that Shayla found that with the advent of EHR systems, the volume of patient notes that we record have just exploded. And as he studied it, he found that 17% of patients, when you're looking at it from a patient-to-patient perspective, 17% of notes have a similarity measure greater than 20%, while 5% of patients have a similarity measure of greater than 50%. So what's happening is that we're creating this needle in a haystack problem. That as the volume gets bigger and as it's harder to find meaningful information, we're finding that these notes are no longer being used to make the patient's diagnosis. And then what I also found is still, with all the work that's happened in hospitals, still researchers, in this case it was Berner, estimated that 15% of diagnoses are misclassified. You know, those 50, and of that 50%, that causes 17% of the adverse effects. So I got thinking that one of the closest views we have to a patient is what happens when they're there with the nurse, or when they're there with the doctor, right? The day-to-day, especially when you first come into the ICU, is critical. We're collecting information, trying to make a decision, trying to see how we can help them. Is there some way that we can take those notes and make them more meaningful to the attending physician? Stockwell talks about this idea of a triggered data point. With all the information we collect about a patient, are there data points? Is there information we can use to help us balance and make our decisions as the patient moves through our care? And it got me thinking, is there a way for me, and this is my research question, is there a way for me to develop a model that can take all those EHR notes and choose a predictive and identify a predictive diagnosis, especially early on in the patient's care? So if I were to take 3 days worth of a patient's notes in the ICU, can I predict what I think the diagnosis is going to be? Because if I can, that can be now a trigger point. Now I'm boiling down all those patients' notes and providing information to the attending physician to say, hey, this patient's notes looks very similar to this whole other set of patients' notes. Consider that as you make your decision. So I'm pulling information that's become unavailable back into the process and helping out. It worked, okay. So the AI problem I'm doing is I'm doing natural language processing step, right? I'm taking all those notes, I'm trying to make sense of them. There are 2 ways I've considered. One is the traditional NLP method. Basically what that does is that takes words that are in the patient's notes and it builds a matrix out of them across the document, which is basically counting the words that are in there. It eliminates words that are unmeaningful and repetitive, like bug and those kind of words. But it builds a matrix of all of them, and that can get fit into a NLP algorithm, in which case I chose Random Forest, to then use that data to predict the diagnosis. The second one is a much more recent technique, and it's one that Dr. Mori alluded to, called large language models. And what this does is this takes the patient's notes, tokenizes them, converts them into pieces, into parts, and builds a string for each note. And part of why this is considered a much more powerful method is that it takes into the context, it takes the context of those tokens much more into account. Each token is increased or decreased. That's not exactly what happens, but it is affected by what words are around it. So words like bank, right? It'd be able to, LLMs will be able to tell that in this case, you're talking about a bank where you're making a deposit versus a bank that drinks their body of water. So taking in a lot more information about what's in that text. And there's been a number of studies that have looked at using either technique to do certain things. Okay. So some of the, as you build a model, you look at what questions you're trying to answer, and that has a lot to do with what choices you're looking at and what choices you want to compare. So like I mentioned already, I use two algorithms. I use random forest and I use BERT. The next question I had was, I can assess how they work accurately standalone. What if I were to combine them into one model? So I'm using information from both models, and that's called an ensemble. Will an ensemble method work better and give me better performance? The other thing I wanted to consider had to do with the closeness of the diagnosis code. If a diagnosis code, and again, my theory is that the nurse's notes is going to be the flavor of the condition the person's in, right? So the person that has cardiac infarction is going to have a different set of patients' notes than if it's a perfect child coming in because they have an asthma attack. So the close of diagnoses has an impact. If they're very different diagnoses, then those are going to be very different. The algorithm probably is going to perform very well. But I also wanted to be able to perform well if the diagnoses were similar. And then finally, when you build these models, there's lots of parameter tuning that goes on. It's called hyperparameter tuning. And in some cases, it's really easy to find the best parameters to use for best performance. In other cases, it's harder. And so I use two techniques to find those on something called cross-validation, and finally an old manufacturing technique called response service methodology. And finally, I keep saying finally. And another thing I considered is those patients' ethnicity have an impact, right? And I think Dr. Mori talked about this as well, that there's lots of horror stories in the business about a model being built that had bias already hidden in the data. So the end result is it worked really well for one population, and just did terrible for another, and in some cases causes liability and all kinds of social problems. So I wanted to be able to check that. Okay, so going back to the idea of distinct versus similar. Oh, first of all, let me tell you that I use the MIT Mimic3 database. It's a database that MIT put together in concert with Harvard, the Harvard hospital system that incorporates a large hospital system in Massachusetts. And looking at the data, I selected 4 very distinct diagnoses. They pertain to a different body system. On the similar diagnoses, I chose 4 diagnoses that were all related to the heart. Now, the combination of those diagnoses plus all the other choices I mentioned before resulted in me developing, fitting, and testing 14 different models. And the names of the models are representative of the choices I made. For instance, RF is random forest, BERT is the BERT model, and ensemble are the ensemble models. This versus similar is a distinct diagnosis or the single diagnosis set. And CV versus RSM are the hyperparameter tuning methods. And finally, in the ensemble, when I built the ensembles, there's a couple of means to do that, to bring the data together. And they are average probability and the stack method, and I have those included. So in the end, I generated 14 different models to test. I used 150 admissions for each set of each model, and they were broken down into various data sets depending on what the purpose of the data was to get to do the testing. Okay, and here are the results, or at least the first set of the results. So of all the methods I chose, the ensemble method that combined the two algorithms that used average probability to combine them, and also used response surface methodology for its hyperparameter tuning, did the best for both distinct and for similar. You can see those in the red margin. You can see across those 6 performance characteristics, that model performed best in 5 out of 6 performance characteristics. So the accuracy on the distinct was 86%, 86.7, and the area under the curve was 83%. For the similar, it was 76.7, 81%. And that's to be expected, right? It's much harder to distinguish things that are similar, closer together than far apart. But that difference isn't drastic, meaning that I think the information is still very valuable to a doctor considering it. Now, one thing that was very interesting, and I was hoping Dr. Murray would refer to this, I should probably ask him, is that what does meaningful mean in a medical setting, right? He talked a little bit about risk and liability. If I came back to you and said, I've got a great model and it produces an accuracy of 43%, who would use it, right? These numbers are high, but what's the standard? So I went to the FDA sites, I went to the AMA sites. There is no standard currently for performance on AI models. I think right now, I think what they're sorting out is let the person using the results decide for themselves what makes the most sense. But I assume at some point in time, those standards will be set, or guidelines, probably is a better word to put it, will be set to make these models easier to use. But what I did find in some of the earlier studies I mentioned early on in these slides, these numbers surpass numbers that have been used in the past. Huang did a study where he looked at patients' notes where he was trying to predict the likelihood for readmission. His UAC number was about 67%. So the fact that in my case I exceeded that at least made me feel that I had improved on the value of this information. Okay, like I said, the last question I want to answer is the role of ethnicity. So what I did is I went back to the data set and I selected an additional 100 admissions for minority patients that were in the hospital that had one of the 4 distinct diagnoses. Because I wanted to show that these models work just as well if it's minority versus the general population. And actually, I found a pretty interesting result. If you recall, if you go down to the second to last line in the table there, it's the ensemble distinct RSM average. That was the best performing model in the general population. In the general population, it was 86.7%. Here, for the minority population, it was 81%. So still a very strong result. Not as high, there is a little bit of a difference, but still a strong result. What was most interesting is that a different model did better than all of them for minorities. And that was the random forest distinct cross-validation model. Now, that actually points out an interesting question about the nature of the patient's notes. Let me see if I can do a decent job of expressing it. So the biggest value, and if you read the research papers about LLMs, the biggest value it talks about is the fact that it's taking context across all those tokens. The BERT model looks at 512 tokens around each token that it's looking at in the patient's notes and assessing the value of that node, value of that token. And the theory is that if you incorporate context, you're going to get a much better result. When you don't, you're missing some information that's in the data, and you're not going to get a good result. But this is saying the opposite. This is saying for the minority population, when we didn't take in context, they did better. They did better by 3%. Now, I haven't proven this, but what that tells me is when you look at when you look at the nature of nurses' notes, the words and the counts of those words are much more important than the words around. Now that surprises me because I think context is very important, but that's what this number told. So I have to, some follow-up research I do is I'm going back and working with the data and see if I can tease out where did that 3% come from. And when you compare the general population, when you go backwards, when you compare the general population, if you just multiply, and you compare the general population only did 78% when you just look at the data with the word out without the context. So that's just something you just kind of pop out of it. So that's the summary of my research. Questions? Yes.
So when you're talking about the nursing notes, are you talking about handwritten notes or is it from an EMR in discrete fields? And I'd be curious if the way that those notes, if they were discrete fields, were set up, if that could contribute to some of what you saw with the minority population having a little bit higher data gathering. Can you tell me about that?
And what I was looking at is in the HR system, and maybe this is something you can elucidate kind of clear for me. In the HR system, they had a string of diagnosis codes. I assumed, this might have been a bad assumption, but I assumed from what all I read, that the first diagnosis is the primary diagnosis. And that's what I used to make the classification. Does that make sense?
Just so I can clarify, I think what she's asking is, this was not from discrete data elements. This would have been looking at raw text. This is the whole conversations that I've had recently about trying to pick like problem lists, for example, out of progress notes and HNP that would be for a string of text, not discrete data elements. It's easy to evaluate discrete data elements, not so easy to evaluate. And then thing that I think is really important is the context, and that he was talking about in context when you find a token name, and then how do you define the context? It's before and after. How many tokens did you say before? Yep. And different models say different variables, right? Front and I'm sorry, I didn't mean to steal your thunder. It's a hot topic within our hospital.
Support to provide this information to the attending physician early in the process. It doesn't do any good if the patient's in there for a month and a half. Okay, this is what I think it is. So I limited my patient's notes to 3 days. So I had the first 3 days of patient's notes to use that, and those are the notes I got. We studied something also about really important information. Yes.
So I'm not sure there's an answer to this, and I'm not sure I should expect one, but any clinician I know is fairly invested in a diagnosis by day 2 or 3. Should we be concerned that this may enhance any confirmation bias that clinicians naturally have by their process? Well, yeah.
Well, I use 3 days. I mean, certainly the same kind of study could be done with 2 days if you think that'd be more beneficial.
Where clinicians ultimately make a diagnosis that wasn't even in their mind on day 1 or 2 or even 3. And I'm concerned that any of these models, not the work you've done necessarily, but they might contribute to that confirmation bias. Oh yes, I'm right. I've got to be right, and may keep us from looking at other possibilities, especially when other pieces of data support the other possibility.
for 10 years worth of ICU admissions. And I'm looking at the final primary diagnosis, and I'm comparing that to 3 days worth of patient steps. So if the attending physician made an initial diagnosis, what I'm matching is an initial diagnosis. I'm matching the final diagnosis. Does that make sense, or am I missing the point?
No, it makes sense. But it's like any statistical value when it's you. They're either right or they're wrong, right? So, and those are the decisions that we end up making in the ICU. You got to think about that zebra occasional.
Yeah. What else?
So in the beginning, you mentioned something about part of your mindset behind this was the onset and ubiquity of cut and paste in notes.
Yeah.
And did you look at I know you looked at a number of things to formulate the direction you're going, but is there an opportunity here to look at, or have other people already looked at, not necessarily whether or not cut and paste was used, if that can be reliably tell, but whether or not notes collections, obviously if it's just Harvard, it's probably just their EHR, but do the various top 5 EHRs out there, do their templates, so to speak, also lend support or hindrance towards this kind of resolution? Or it's not the providers doing cut and pasting, but it's the way the templates for that particular system were laid out push people one direction or another. And the other thought I had was there's a lot of conversation about ethnicity in a lot of fields in this stuff, and a lot of it always focused on the patient's ethnicity. And I have to wonder, based on what you were doing here, would there be any conclusions worth looking at or drawing if we looked at the data comparing not the patient's ethnicity necessarily, but the provider or the note writer's ethnicity, and maybe even the note writer's ethnicity in conjunction with the patient's ethnicity? In and of themselves, or in correlation to what the patient's ethnicity is.
On the heels of that question, what about English language proficiency with both parties?
So that is on both sides. However, like the case of the where are they going with that? Like the case that I found, this hospital system had, I'm not sure if I told you guys, the hospital system had 72% white population in patients, which is much higher than other parts of the country, and that's why I did the study. But you're right, it could go anywhere. So some for both. Any other questions?
I was only curious too, I guess maybe as a future opportunity where EMRs are starting to take notes with the patient in the room, and then the AI is creating a generative summary of the notes between the physician and the physician going through them and finalizing it, but it's taking into account that entire conversation and then having an output of that. And then whether or not basically some of these percentages would be the same or different. Based on that and the quality of the note in that context, or if you came across any of that research while you were doing this project. Right. So if a patient and a physician are having a conversation in a patient room and the AI is transcribing essentially and then analyzing and creating a final note that the physician, audits, signs off on, but then too, how might that be different?
They still let it. Okay. But my guess is they're probably a lot less likely to cut the paste. But that's a good point. Yeah. Anything else? Okay, guys, thank you very much.